A 5-year-old boy is brought to the emergency department with fever, lethargy, and decreased urine output for the past 24 hours. On examination, she is drowsy, tachycardic, hypotensive, and has delayed capillary refill. She has cool extremities and poor peripheral pulses. She weighs 20 kilograms. There is no history of diarrhea or vomiting. And her respiratory rate is 30 breaths per minute, with oxygen saturation at 94% on room air.
I really don't feel well.
Question 1. What is the most appropriate immediate treatment for this child?
The most appropriate immediate treatment is fluid resuscitation, with an initial bolus of 20 ml/kg of crystalloid, aiming to improve her circulation and cardiac output. Since she weighs 20 kilograms, the initial bolus would be 400 milliliters.
I hope they have an answer to every question, or I'm in trouble.
Question 2. According to current guidelines, how much fluid should be administered in the first hour for pediatric septic shock, in settings with intensive care support?
In settings with intensive care support, up to 40 to 60 ml/kg of fluid can be administered in the first hour. For this child 20 kilograms, that would mean administering 800 to 1,200 milliliters of fluid over the first hour, with continuous monitoring for signs of fluid overload and improved perfusion.
Question 3. If the child remains hypotensive after receiving 40 milliliters/kg of fluid, what should be the next step in management?
If the child remains hypotensive after receiving 40 milliliters/kg of fluid, the next step would be to start vasoactive agents to improve vascular tone and cardiac output.
It looks like they have no other options.
Question 4. What factors should be considered when choosing the type of fluid for resuscitation?
When choosing the type of fluid for resuscitation, consider crystalloids, normal saline or balanced solutions are generally recommended for initial resuscitation due to lower cost, availability, and reduced risk of blood-borne infections. Colloids, such as albumin or hydroxyethyl starch, HES, are generally not recommended for initial resuscitation due to lack of clear benefit and potential risks like AKI.
Question 5. Why might large volume fluid administration be harmful, particularly in low-resource settings?
Large volume fluid administration may be harmful due to dilution of hematocrit, especially in patients with conditions like severe anemia, which can reduce oxygen delivery to tissues. Exacerbation of heart failure, especially in children with comorbidities like malaria or severe anemia.
The FEAST trial demonstrated higher mortality in children receiving fluid boluses compared to those receiving maintenance fluids, only in settings without ICU support.
We should find out if the hospital is in the intensive care unit.
Question 6. What are the Pediatric Surviving Sepsis campaign recommendations for fluid resuscitation in pediatric patients without intensive care support?
The Pediatric Surviving Sepsis campaign recommends fluid administration only if the patient is hypotensive